Hello, everyone, and welcome to our 2024 Western Canada PKD Patient Forum. My name is Michelle Lynn Goodfellow, and I'm the Communications and Engagement Manager for the PKD Foundation of Canada, which is the only national organization solely dedicated to fighting PKD through research, education, advocacy, support, and awareness. This session is presented by nephrologist Mike Bevilacqua with a patient story from Kelly Konieczny. Dr. Bevilacqua is a nephrologist with additional training in health administration. His clinical nephrology practice is based in Surrey, British Columbia, and he's involved in several administrative roles with BC Renal. He is the chair of the Provincial Kidney Care Committee, which coordinates care delivery for over 15,000 British Columbians living with chronic kidney disease, the medical lead for the BC Polycystic Kidney Disease Network, which aims to optimize management of PKD in BC, and the co-chair of the Transplant First Committee, aimed at improving access to living donor kidney transplantation. Dr. Bevilacqua also works with BC Renal on other initiatives, such as improving the delivery and support of home dialysis therapies. When not doing clinical work or at BC Renal, Dr. Bevilacqua is involved in research with specific interests in care of patients with polycystic kidney disease, knowledge translation, systems improvement, and evaluating care delivery, and is also actively involved teaching at the medical school and residency levels at UBC. This is Dr. Bevilacqua's presentation.
Thanks so much, and thanks for having me for one of these events again. You know, we've done this several times now, and it's always just such a great opportunity to share with the PKD community and be able to engage. And I'm so glad this will be recorded, so please check it out if there's anything that we need to cover again. Great, so we'll launch into it. It was a perfect introduction. You see, it almost matches exactly the title of the talk here, and really it's meant to cover the whole spectrum, kind of a whirlwind tour of PKD, all in less than an hour here. Before we get started, it's worth mentioning a couple of financial disclosures on various other work that I've done. Very pertinently, though, is that there is one with the manufacturer of Tolvaptan, and to mitigate that, I only ever talk about published data in relationship to this medication. Okay, but otherwise, to launch into the topic again, this is the whirlwind tour where we'll cover the whole spectrum, right from what exactly is PKD, what does the diagnosis mean for you and your family. We'll get into some options, what I like to call living well. How do we manage throughout the lifespan of someone with PKD? And then we'll talk about some specific treatment options at the end. To start at the beginning, though, PKD, and actually specifically, I should say, since the PKD Foundation does help people with both, we're talking mostly about autosomal dominant, or ADPKD. That's what I'm going to talk about through this session this evening. I'll often just use the term PKD interchangeably, but really we're talking about ADPKD. So this is a genetic condition that is actually quite common. One in about 500 to 1 in 1,000 patients, or people depending on population estimates, is actually very, very common for a genetic disease. Or as I like to tell people, it means just for the random person walking around on the street, they probably know someone in their circle of life who's been affected by polycystic disease. It's that common. And in the kidney world, we see a lot of this. It makes up about 10% of the people that we see. So what polycystic disease is, it's a genetic disease where you tend to form these cysts. The name polycystic just means many cysts. It can be quite normal to have 1 or 2 cysts in your kidneys, but people with polycystic disease develop more. Your normal kidney, a healthy kidney without cysts, is about the size of your fist. And in people with polycystic disease, what happens is they get more cysts. We'll talk about the progress as it expands, but because of that, the kidneys actually get larger and tend to accumulate these cysts, these many cysts that make up that polycystic disease. Before we talk about progression, I always like to answer this question because it's a common one people have, is when they hear the word cyst, what exactly does that mean? So if you think of your kidney, you've got this big structure here, but what it's really made up is 1 million of these units, about 1 million on each side of these filtering units called a nephron. And what a cyst is basically an outpouching or an out pocket on one of those nephrons that then over time can grow and fill with fluid until it looks like a cyst. I specifically like to mention, because often when people hear the word cyst, they worry is this something worrisome or a tumor or something like that, because in other contexts, that's what cyst could mean. Here in the kidney, when we're talking about a cyst, think more like bubble wrap, a little pocket that just has a little bit of fluid. It's basically kind of like urine that's in there. that type of fluid, but it's not anything worrisome like a tumor or something. It's a bubble. It's a pocket of fluid that grows. So people with this condition that have this gene that triggers them to develop these cysts, they tend to develop more. And then let's talk a little bit about how this might progress through the course of someone's life. One of the first things that people with polycystic disease will notice is nothing. And that's why I have it at the bottom. It's actually early on in the disease, you wouldn't necessarily notice a thing. Being a genetic disease, it starts occurring from even before someone's born, while their body's forming, kind of in the womb there. And it starts off very microscopic and small, basically no impact at all. But then as things progress, it's when you might start to notice some things. And we have here listed some of the common first clues that people might get. You know, the obvious one people would think of is things like pain or fullness, and then very extreme things like blood in the urine, kidney stones, or frequent infections. Those ones, when I say that they're more apparent, they're more obvious. But things like, you know, early blood pressure. I meet a lot of people who, you know, they don't get their diagnosis to a few years later, but when you talk to them, they say, oh yeah, well, since I was 30 years old, my doctor always used to tell me that my blood pressure was high, which right there, it's a bit of a clue, because someone who's otherwise young and healthy would expect to see high blood pressure. So that can often be an early sign of the disease. But any of these things might come up, and again, frequently people can be asymptomatic and we don't know till we go looking for it, which I'll come to in a second. But before we talk about how the disease itself is diagnosed, it is good to talk about the whole spectrum of disease. And I love this slide when it comes to polycystic disease. So it's basically the whole thing in a nutshell. So what happens when you have this gene that makes you predisposed to make cysts, this polycystic gene, is that over the course of your life, you tend to get more cysts, and the cysts you have get bigger. So this is meant to show time going on. This is kind of a kidney, all that brownish stuff is normal, healthy kidney tissue. And you can see there's a few cysts in there, but early on, it doesn't really cause much of an impact. The cysts kind of get bigger and bigger, and you get more of them. And what's really happening is it's not the cysts themselves that's the issue. It's a little bit more complicated than this, but think about it almost like what they end up doing is making it so that other healthy kidney tissue can't do the job. Because even though the cysts only occur in a minority, actually a very small minority of the nephrons, so they said you might have 1 million of them, and maybe in someone with a lot of cysts, they have, you know, several hundred or 1,000. It's only a small amount, but what they do is they make it so those other healthy parts of the kidney can't do their job. So this process proceeds. This line up here in red is meant to represent kidney function, or GFR. And you can see that what it's labeled as is it's a straight line. Oops, I clicked there. It's a straight line through much of the disease, but then later on it starts going down. Or as I like to tell people, by the time you see a change in GFR, actually a lot of the disease has already happened. So a lot of this happens before you notice any change in blood tests. So it really is important to be monitoring people and kind of come up with plans before that kidney function ever change. And then, yes, ultimately, as time goes on, this being a progressive genetic disease, the kidney function will go down. But the very important thing to say about when that will happen is that it's quite variable. You know, we used to do things like tell people, well, there's a 50% chance by the time you're age 60 that you'll need dialysis or a transplant. Well, 50% is like flipping a coin. You know, what we've really learned is it's a wide spectrum. I see a lot of people with polycystic disease, and at the most aggressive end, I've got people who are kind of in their late 20s when I'm getting ready for a transplant. At the other end, I've got patients who, yes, they have polycystic disease, but, you know, they live their lives until they're in their 80s, and maybe their kidney function's not perfect, but it's still working, and then they pass away from something else. Right? So it can be all the way from trouble at a very young age to needing a transplant, to never needing a transplant or dialysis, and then literally everything in between. So there is quite a lot of variability, even within a family where people share the same gene that causes the disease, we see a lot of variability. So this is the general process of the condition, but it plays out at different times for different people. So that's the course of the condition. Now let's talk about how we pick it up and then how we manage it. So in terms of diagnosis, there's essentially two ways that people come to us. One is that They come from a family where they know they have polycystic disease, so they get tested, and then we determine the condition. But the other that happens in about 25% of people is there's really no known family history at all. They either show up with a symptom like abdominal pain or an infection or something like that, or sometimes they even just have a scan done for some totally different reason. Like I've had patients who, have been in a car accident, they get a scan done and it shows the cyst. They just happen to discover it on the imaging. So those are the two ways people might come to us. In terms of making the diagnosis, though, what we really do then is, for most people, we use those imaging tests to determine the disease, because polycystic kidney disease actually shows up in a very typical or classic way on the scan. So actually, most of the time, you can see our diagnosis is confirmed with, it says ultrasound, a CT scan, or MRI. Very rarely do we ever actually use genetic testing, and I'll talk about that in a second. But usually we're able to tell this with those imaging tests. And that's how we make our diagnosis. I just mentioned that we don't, use a lot of genetics, which seems weird to say for a genetic condition, that we don't actually often do a lot of genetic testing. It's not that we don't know the genes. Actually, we know quite a bit about the genes, and we'll talk about this now. We know that most commonly, there's two main genes that can be causative for polycystic disease. We call it PKD1 or PKD2. There's actually quite a few more now. We've identified actually about 10 different genes as the years have gone on that might cause this, but about 90% of them are one of these two. So these are by far the more common ones. And you can see that we put some different categorizations of these two. We say, well, in general, PKD1 can be a faster form of the disease, where you more quickly might run into trouble with kidney function needing transplant or dialysis. PKD2 might be kind of a slower form of the disease. But again, we've actually learned as time goes on that there is significant overlap between these two. So knowing the gene type doesn't really tell you what to expect for a person in front of you. Meaning, there are definitely people with PKD1 mutations who actually have a pretty slow form of the disease, and there are people with PKD2 mutations who have a very fast form of the disease. So that information doesn't actually tell us a whole lot in terms of which gene they have. It doesn't tell us what to expect for the person in front of us. And so although we know about these different mutations, and if you happen to have genetic testing done, it's good to have that information, we don't actually pursue it most of the time. This is really when we might think about it. And I do like to explain it, because actually one of the common questions I get is, why haven't we done genetic testing? And it's because it doesn't actually change what we're doing. The times it might is in one of these situations. What a lot of them really come down to is if there's something out of the ordinary with the person in front of me. Meaning, maybe I told you we usually can tell based on the imaging test what it looks like. Well, if it's not exactly classic for that, if it's not exactly typical appearing, that could be a reason we do it, especially if there's not a family background of the condition. Again, a lot of people, about 25% of us, will come to us without a known family background, but it is one of those reasons that we might look a little bit harder and get that genetic testing to really confirm the diagnosis. And you can see some of these other specific planning reasons. So one is basically if we're not sure we have the right diagnosis, and then the other group of things is a couple of specific planning reasons, being if you come from a family with polycystic disease, but you don't think you have it, but you want to be sure in case you want to donate a kidney. That's one reason we might do it. And another is if people are thinking about family planning, which we'll talk about in a second here. But the short answer is we don't often do this. It's actually a minority of people we do genetic testing for. In terms of family planning, that is kind of what I wanted to lead into, because one of the questions is a very common question is, what does this mean for my family? So I love this picture that you guys made from the PKD Foundation, because it really shows how the condition is inherited. That AD in ADPKD stands for autosomal dominant, which talks about the pattern that it's passed down through families. And what it basically means, you can see that this is meant to, each person has these 2 copies of a gene. We have 2 copies of each gene. This person who has the condition, he has this orange one that shows that he's got the cysts. One of the 2 copies has it. And what that AD part means is that it's a 50-50 chance that he might pass it on to each of his children. It doesn't matter if it's a boy or a girl, it's 50-50. So, coin toss each time that it might get passed on. If the child has it, then that means when they ultimately go on to have kids, they have a 50-50 chance of passing it on. But I also like to say very specifically, this is not a condition that skips a generation, meaning, so for example, these two in the middle that don't have the gene, they do not have to worry about passing it on to their children. So it's kind of like 50-50, and you either have it or you don't. If you don't, it stops in that branch of the family tree. But if you do have it, then that 50-50 starts over again. And so people, and there are some specific, family planning methods people can consider if they're looking into having children try not to pass this on. But the other big question that I get is, okay, so now knowing this, if I have children already, should I get them tested, and when should I get them tested? And also, maybe I've got a brother and he's not been tested. How do I talk to him about being tested? So there really are pros and cons to both, and I kind of like to talk people through. It's a very individual situation. I have people from families who, they know a lot of the family has polycystic disease, and they say, you know what, I feel fine right now. I would just rather not know. I'm not going to get tested. And then I have other people who say, okay, how can I test me and everyone else in my family as quickly as possible? Right? It is a very personal type of decision. You can see that there are some reasons. I actually think there are a lot of pros, and actually in most cases, the pros outweigh the cons. Specifically being that it's always better to have the information and know what to do with it. We'll talk in a bit about treatment options, and for a lot of them, the earlier you get things going, the better people do. So that's quite a reason as well. And then, knowing exactly what to expect to the family, right? Rather than sometimes you find out that you don't have it, and then you don't have to worry about the kids, right? If you come from a family with known disease. So I think there's a lot of pros, but it is worth knowing that there are downsides, right? A lot of people feel like there's just this burden of having it hang over their head, and that's not to be discounted. That's very real. There are, unfortunately, considerations around things like insurance and things like that do play into people's decision making. So there really are ups and downs. So I like to talk to each individual, kind of take them through this, and then, if they decide to go through it, it's not like it's an invasive test. The first thing we would do with most people is an ultrasound. Their family physician can set that up. And then the important thing is, if positive, to go ahead and get linked in with a kidney doctor quite quickly. If people decide not to go ahead and get the testing, again, I think that's fine, but then I often will give people these instructions. Remember earlier we said things like, okay, blood pressure can be an early sign, things like infections or kidney stones or stuff like that, and then obviously change in some of your tests, like your kidney function or your urine test. So if someone decided not to be tested, I tell them they should be looking out for these things, because if one of them comes up, then now we have a reason we kind of have to go ahead and test. In other words, when we're doing testing before anything comes up, it's called screening, meaning doing testing in someone who's asymptomatic. But once you start to have symptoms or complications, it's a different story, and then we need to go looking, and so that we can treat it appropriately. So if someone decides not to do testing, we say be on the lookout for these things, and if they happen, you got to let us know, so then we can get going with the testing. Okay, and then lastly, I just like to put this plug. We've got all of these great resources out there that go into this in a little bit more detail, because it is a complicated situation. I love this. It was one of these ones we made a couple years ago. It was actually a great partnership, us at BC Renal, the PKD Foundation, as well as the Kidney Foundation of Canada. We actually all put together these resources around testing so we can all use them. So we have the same information, kind of a one-stop shop. I think it's a great source, specifically takes through a little bit more of the nuance if it's a question that you have. So this is available on any one of our websites, and it goes through all the pros and cons of testing. I think one of the most common questions is specifically some considerations about testing young children. The short answer there being, in most cases, we say if they're asymptomatic, you can wait till a little bit later into childhood or even early adulthood, but it actually takes you through all of those considerations. So please, if it's a question you have, go and check out these resources. They're a great one to look at. Okay, so that was the whirlwind tour of the disease itself, how we go find it in individuals and families. And now we're going to spend the whole rest of the time about managing it in an individual who has polycystic disease. So this first section I like to call living with PKD, which is really talking about the lifestyle, measurements or measures that we take in people with polycystic disease. So a lot of these, if you look across this board, I'm not going to read them out. You can see all little pictures here. They're really general, good, healthy lifestyle things, right? Like maintaining a healthy weight. It actually specifically has a benefit in polycystic disease to maintain a healthy weight, avoiding smoking and being active. Those are important. Caffeine intake. I love this one because it was such a common question that people actually did a scientific study on it. And what they found, you'll see it in the slide in a second, but less than about 250 to 300 milligrams caffeine a day, which think of that as being somewhere in the neighborhood of 2 to 3 caffeinated drinks a day, is kind of the upper limit. Above that, it's where it starts to cause issue, but below that, there's no problem, meaning you can have your 1 or 2 cups of coffee, and I can tell my patients, we have good data to tell you there's no risk of that, but more than that, it could be a problem. And then these items are more kidney specific. Make sure you're drinking lots of water, avoid these non-steroidal or basically drugs that are hard on your kidneys, and make sure your blood pressure is managed well. I want to specifically talk about diet though, because it's always the question that comes up. And again, most of this is just a general healthy diet. When you go looking through a lot of resources when it comes to kidney diets, you'll see things like sodium and potassium and phosphate, and it seems like just a whole laundry list of different chemicals. And some of that is true, but I basically tell people that, 90% of the job is that if you're having a good balanced diet, and if you're going to be strict about anything, it's cutting out highly processed foods. That's probably 90% of the battle. Salt is one of the biggest ones, and most of our salt comes from processed foods, as well as all of those other additives that we're worried about. So just by doing that, you've got most of the job done. But then there are a few other considerations, things like making sure that you're keeping yourself well hydrated, and especially for people who either have questions about it or some people who have more than one health condition, that's where a specific kidney dietitian can really be helpful, right? Especially when you're balancing multiple different diets that you need to integrate, that can be quite good. But again, the biggest ones that we can tell people for sure is to maintain a healthy weight, good balanced diet, trying to cut the salt and keep yourself well hydrated, and that's most of it. It's another one of these topics that was so common that actually this group out of the Mayo Clinic did a big review of it. And this is a very busy slide to take it from their scientific paper. But you can see it's really the big headings that I like to talk about, where we're aiming for a healthy weight. We're aiming, when it says hypotonic urine, it basically just means keep yourself well hydrated. That's really what that's saying. Hypotonic urine means aiming for kind of that pale yellowish color to your urine. That's how you know you're always well hydrated. Having enough protein, but not too much. We used to tell people to protein restrict. We now know that's not the case. That's why the wording says adequate dietary protein. You just don't want to go overboard with protein. So you can see things like in the neighborhood of around 1 gram per kilo per day, which is a pretty, fair protein intake for any diet. And those are the big ticket items. Very specifically, they put it on here, and some people may have seen this online. Some people actually use some of these supplements that contain ketones and or citrate supplements, which there's still not enough evidence there that we're recommending it to everybody. I know some people who have tried it and would find benefit for it, and there's certainly no harm for it. There are some studies ongoing, and it may be that it ends up having a benefit. But right now, I would say the data is not in a place where I'm going out recommending this to everyone. I also say that specifically because it is something that comes at a personal financial cost. You got to pay for this, right? So since the data is not there yet, I'm not telling everyone you must go do it. Some people find it beneficial, and if you want to pay for it, by all means. But otherwise, the answer that most of us are saying from the kind of scientific perspective is stay tuned. There are some studies going on, and probably in the next year or two, we'll have that answer as to whether or not they do have benefit. So you can see even this group out of the Mayo Clinic right now is saying there's not enough data to go recommending that to everybody. I just like to mention it because I know it is out there quite a bit. Exercise, I always like to mention this is a common question we get of, what should I be doing? Should I limit anything? I often tell people there's not a lot that I would limit you to do. It's true that there are times that a cyst can actually rupture, it can pop and cause some pain and some bleeding. For that reason, I tell people to be careful with really high impact sports. But that said, I have patients who are, professional, I won't say what, but sports players that are quite high impact, and, they know the risk and they want to go ahead with it. It is true that maybe sometimes people might go for a jog and have a cyst rupture or something like that. But I always tell people that if that cyst ruptures when you're just going for a light jog, it was going to go anyway. It may have just gone when you rolled over in bed one day, meaning it was about to rupture. So it's all to say that find an exercise that you like and do it. And actually, outside of extreme sports, there's not a lot of things I would really, caution people about. Water intake, actually, we already talked about this. I got into a little bit more detail in the last slide, saying that, we tell people aim for that 2 to 3 liters, or always maintaining that pale urine color. That's how you know you're getting enough. And then the other last little point there that I like to make about water intake is that it's not just the amount, it's that you're consistently drinking through the day. Meaning, if you go to work all day and you don't really drink anything, and then you come home and drink 2 liters in the evening, you're not really doing yourself any favors, because that whole 6 or 8 hours or whatever it was where you're dehydrated, that's actually when it causes some problems with your kidneys. So making sure you're kind of always sipping away and always keeping yourself well hydrated is an important thing. So those are the lifestyle measures. And then, the other part that I think is really big when we talk about living with polycystic disease is living with some of the complications that can come up. And one of the biggest ones is pain. There are other complications that come, but obviously this is what people notice, because pain is not a subtle thing. You notice it, it comes to your forefront. And there's quite a few things that can cause pain in polycystic disease. There are more kind of sudden, or what we call acute events, things like that cyst rupture we just talked about, stones, infections. That's kind of a bang, sudden type of a pain thing. But then there is also pain that comes just as the organs get bigger and kind of push on things and displace things, more of a chronic or a longer term type of pain. So to help people kind of understand and manage this, we made some resources around this, again in partnership with the Polycystic Foundation and the Kidney Foundation of Canada. Living with pain and polycystic disease. Again, same websites you can download that from. But I also, like to point this out. So this came out about a year ago. Again, another big scientific study. Polycystic disease, it's a really active area of research these last few years. And I love this one because a lot of the research was getting into, treatments, which is obviously very important. But this study was really talking about different types of pain that people experience with polycystic disease, and how do we categorize it, because we do manage them differently. I won't go through every topic here, but basically what you can see is that it talks about 3 different pain types. And once this came out, this was one of these aha moments, because it really put into words what all of us had been seeing with the patients in front of us. That you have some people who, as we said, this one in the middle is that sharp, sudden pain. That's a very, very different thing from kind of a longer term, dull, achy pain. And then there are some people who don't have pain per se, but a lot of fullness, which of course is a symptom in and of itself. So now we talk about these different types of symptoms, and we talk about not just what type of pain it is, but you can see when it says domains, it says severity and interference for each one. So basically, when we're thinking about pain, we're looking at, okay, what's a description of the type of pain you're having? How bad is it? And how much is it impacting your activity? And so for all of you as people living with polycystic disease, being able to kind of think about it in these ways can be quite helpful, because then when you go to meet with your doctor and you can kind of describe it, because pain can be a tricky thing to describe, right? So you think about these type of categories and how might I describe it in those ways, it can kind of help put your doctor down a path of, okay, how are we going to manage this? What are we going to do here? Because we do manage them quite differently. Those acute sudden ones, really it's about, okay, how do we get you through this episode, and when do we need to get you to emergency or get more urgent care? For those dull pains, we have a lot of chronic pain management strategies that we're talking about. And then for the fullness, we also use those chronic strategies, but that's also where sometimes we might even consider interventions to kind of decrease the size of the cyst in the kidney. So being able to split it up is helpful, because we do treat them in different ways. And again, there's a whole lot of resources out there. These are the ones that we made together with the Polycystic Foundation. Again, you can get them on any of our sites where it talks about the pain itself. There's also a pain journal that kind of is a helpful tool. And actually, not that I'm just plugging myself, but actually last year for the virtual PKD Summit, I did a whole talk specifically just on pain management, the whole topic in and of itself. And so if you're looking for more information, that recording is available out there on the PKD Foundation website. Okay, we're going through a whirlwind here. We're covering basically all of PKD in like 45 minutes. So, so those are living with it, management strategies, and managing chronic pain. But now let's talk about, medical treatment options. What are our treatment options for polycystic disease? So The way we approach this now, this is kind of the modern way that we approach polycystic disease, which again has really changed over the last 10 years, where we say, okay, we've got someone with the disease, we confirm the diagnosis, then basically we walk down this pathway, which again, I won't go through all the technical parts of this from that scientific paper, but it's basically saying we establish a diagnosis, we prognosticate your renal outcome, meaning we try to predict, are you going to be more like that 20-something-year-old who's going to have very aggressive disease, or more like that 80-year-old who's never going to run into trouble? So figure out, what do I think is going to be the progress of the disease for the person in front of me, and then we select treatment options. We have some basic treatment that we apply to everyone, and that was a lot of those lifestyle things that I just talked about, as well as a couple of other points I'll come to in a second. So stuff we do for everyone, and then a few targeted treatments that we use for people who are progressing more quickly, and we say, okay, it's worth it now to be more aggressive with our treatments. That first step that I took you through in that algorithm was to determine, okay, predict who has more rapidly progressing disease. And so the way that we do this, back when I was showing that first slide with the pictures of the kidneys and show them getting bigger, we've learned over the years that yes, we can follow your kidney function, but actually we've learned that you can look at how fast those kidneys are growing. And that's a big predictor of what to expect. It's actually by far the strongest predictor we have of what to expect with someone. So what I mean by that is, some of you may have seen it, some of your doctors may have shown this to you, where we have this classification for polycystic disease, where on going up the picture, we have how big your kidneys are, and going sideways is how old somebody is. Meaning if you put the two of those things together, it's saying, how fast are your kidneys growing? Somebody whose kidneys are growing really quickly because of the cysts are going to have a more aggressive form of the disease and progress more quickly, whereas someone who's doing it more slowly will have a milder form. And so some of you may have seen this, where I love doing this with my patients right in the room. There's actually a tool online where you can do that, and it actually shows them right where they are. So you can see kind of this visual of where do you stack up, for the whole range of possibilities of polycystic disease. So this is that first step, and back in that algorithm, you'll see that it actually, and most of the guidelines we follow now, this is how we determine which types of treatments to use for people, based on if you're growing more quickly, we're going to be more aggressive. If you're growing more slowly, we know actually you're going to do quite well, and then we'll be less aggressive with our treatment. So once we have that information, we can then go and say, okay, which treatments are we going to be looking at here? The basic stuff that we do for everyone, we call it basic optimized management, meaning it's the foundation. Everybody gets this. Most of this you can see are those dietary items we talked about and lifestyle items. And then the other one is blood pressure, which I'll talk about here in a second. And that's basically the package we do for everybody. We already talked about those diet measures, but blood pressure is actually a really important one. We aim to control blood pressure quite aggressively in people with polycystic disease. And there's two reasons for that. One is that specifically getting your blood pressure lower helps slow down the progression of polycystic disease. There was actually a big study done on that. So we know that what we call an aggressive blood pressure target slows down the kidney progression. So that's obviously very important. The other thing that I like to remind people is a lot of the consequences we worry about with high blood pressure are long-term consequences, things like the impact on your heart and strokes and things like that. Well, most people who develop high blood pressure develop it later in life, right? Say maybe you're 50 or 60 years old. That means you've got maybe 20, 25 years that you really have to worry about the consequences of it. But as we said earlier, one of the early manifestations of polycystic disease is blood pressure. So if you develop high blood pressure when you're 20 years old or 25 years old, all of a sudden now you've got 60, 65 years you have to worry about the complications for high blood pressure. And that's why over that long term, every little bit we get it lower, magnified over 50 years makes a big difference. So in other words, the younger someone has high blood pressure, the more aggressive we are with treating it. So for those reasons, with polycystic disease, we actually treat blood pressure more aggressively than we do even in the average person with kidney issues. So that often means people go on blood pressure medications and will do so in, at a younger age. And I kind of tell a lot of my patients living with polycystic disease that this is something we're going to be doing for the rest of your life. So getting in the habit of being on top of the blood pressure just becomes, you know, a part of your lifestyle and something that we make part of your self-management. And so along those lines, I actually recommend this to a lot of people, is the value of doing blood pressure monitoring at home. We know that it's actually, in many ways, it's better than doing it at the doctor's office. You know, the phrase I give to kind of drive that home is, when we're talking about blood pressure, what we really care about is your blood pressure at rest, not when you're at a doctor's office, which is the exact opposite of that. In other words, most people who just get their blood pressure checked at the doctor's office, you're getting checked at the worst possible time. You want to be checking it when you're at home, not doing anything nice and relaxed. That's your real blood pressure. And so getting into this habit can be, you know, I think a very, very useful thing, and I actually recommend this to most people, to be doing the monitoring at home. You can get these little machines now, you know, they've come a long way. They're very cheap. You can get one at Costco or something like this, or any drugstore for, you know, 40, 45 bucks, and they're very accurate, very, very affordable. And since it's something you'll be doing, you know, over the long term, it's often a very good investment and helps you just to be in control of a significant part of your condition. So definitely a good thing to do. And these are some resources, again, that we have to assist people with blood pressure monitoring. Okay, so that's the stuff we do for everybody. But then we also have targeted treatments. Oh, maybe my color went away there as I went through the slides. But we say, okay, in people who are progressing more quickly, we do have some specific targeted treatments. And the one that we really talk about, the one so far, we're all very hopeful we're going to see more in the near future, but the one so far is this drug called Tolvaptan. And what this drug is, it blocks a specific hormone in your body called vasopressin that does a couple things. The benefit that we're going for is that hormone stimulates cyst growth in polycystic disease. So by blocking that hormone, that process slows down. It also does some other things, though, which I'll come to in a second, that basically think of it as that hormone, what its actual job in your body is to control how your body handles water, and specifically to keep you from kind of getting, to make sure that you have the right amount of hydration. And when we block it, what ends up happening is that people make a lot of urine, and because of that, have to drink a lot of water. Okay, so we block it, but it comes at a cost because we're interrupting the hormone system in the body. In terms of the effects, though, you know, the way I always like to describe this to people is this, again, this is not a cure. So what it's meant to do is slow down the process of the kidney disease. And these lines, it can look a little bit busy, but basically what it's showing is that when people are on treatment, we say that on average, for about every 3 to 4 years that you're on treatment with Tolvaptan, you'll get another year of additional good kidney function. So when I say it that way, you can recognize a couple things. One is that it's a long-term treatment. It's not something we do for 6 months and carry on. The benefit is over many years. And the other is that although that doesn't sound like much, it's like anything else. I tell people, think like making an investment. It compounds over time. The earlier you start, the better off you are. And that's what these lines are meant to represent, that you can see the gray lines and the black lines show the separation between someone who's not treated or not treated. And yes, even if we find someone and later in the disease, we get a benefit from treating them. But you can see the earlier and earlier we start, that difference magnifies, right? And you can really start kind of changing somebody's outcome. So it's a long-term treatment, and one that's meant to slow down the process. It still goes forward because it's not a cure, but it slows it down, gives us additional time. Now, that has that benefit, but one of the questions I often get is, you know, why do we not consider it in everybody, though? And there are a couple of items. You know, one is that in a small percentage of people, it can cause some issues with the liver. So because of that, we need to do tests once a month for the first year and a half when people are on the drug, just to make sure they're not one of those people. Now, if it happens, it's a completely reversible thing, meaning you just stop the drug and nothing happens. You know, there have been actually, since the initial studies, there have been 0 people who have had bad liver outcomes because of it. So it's safe with that system, but needs a lot of monitoring. But the biggest thing I think for people to work into their lives is that way that it changes how your body handles water. So this is actually what I spend most of the time talking to my patients about before they're going to start the drug, is that it really increases the amount you're drinking and the amount you're peeing. The drinking part people don't really notice or mind because they're thirsty, so you want to drink water. It's the going to the washroom part. That really is what I tell people you need to kind of think about if you can work that into your life. The average person might pee about a liter, a liter and a half through the course of the day. When you're on this medication, it's on average 4 to 5 or even more than that. So just being able to work that in. So because it comes at that with those side effects, that's really why we're making that difference. Because one of the questions, again, is, well, why don't we just do this for everybody? Well, what we're really trying to do when we select people for treatment is, I keep going back to that same example. If you're going to be like that 80-year-old who lives their whole life and never runs into trouble, the last thing we want to do is put you on a drug for 40 or 50 years that has a lot of side effects, and you would have been fine without it. So that's actually what we're trying to avoid. We're trying to select the people who are actually going to progress and use it to slow down their progression. And I like to put it this way, because I've met a lot of people with polycystic disease thinking, oh, my doctor never talked about this or said I shouldn't use this medication, or almost like, are we holding out on you? And actually the message is usually, no, that's often usually a great thing, because it means that you're progressing slowly enough that we don't think the benefit is worth the risk in you. And that's really kind of that balance that we're looking at. And then sometimes what a lot of nephrologists will do is say, okay, right now it doesn't look like a fit, but let's monitor, and if there's an indication for it that comes up down the road, then we add it in. So that's really our decision-making process, is thinking, are the benefits worth the risk, especially because this drug does have more risk than some other drugs out there. So that's why we really have to think about it. One of the common complications, that we, one of the common questions actually we get is, can you do the same just by drinking a lot of water? And actually, I'm not going to get into the data here just in the interest of time. I have the slide already prepared, but suffice it to say, in the studies that they did of this drug, it actually was compared to people drinking a lot of water. And we learned two things. One is that it works better than people drinking a lot of water. And the other is that you can't really make the same effect just by drinking water. In other words, it's almost impossible to drink enough water and have the same effect as this medication. So if you're the type of person that your doctor thinks this is a good fit for you, to answer that question, no, you can't really make up for it just by drinking lots of water. This does do more than you could do just by a lot of water intake. Okay, so, those are the big items around the kidneys. I'd like to mention this now, now maybe in the interest of time, I'm not going to go through all of these, but it's just a reminder that polycystic disease is a whole body condition. So there are other parts of the body that we kind of look at and do some specific testing for. Since it's a genetic disease, every cell in your body has these genes, so we can have different manifestations. The two that I like to specifically talk about in a little bit more detail is around things like the liver cysts, because it's so common. The way I like to describe this is actually most people, so about 80% of people, have some cysts in their liver. Tends to be more in women than in men, because there is actually a role of estrogen in the liver cyst formation, not the kidney cyst formation. So most people have some involvement. Some people have significant enlargement of their liver, but only a small minority of people run into trouble with their liver function. Now, the way I like to put that all together is, although that's a small minority of people, for those people, it's a really big issue, right? So it's kind of like, it's common to have cysts, less common to run into trouble, but it can, when that does happen, it can be a pretty big one. And that's where we often will get other teams involved, including the liver team. And I have a good handful of patients who actually have had both liver and kidney transplants, because it affects their liver that much. So the liver, it's all to say, it's something that we go looking for, and in those cases, actually, where we might get a whole other team of people involved. And then the last one that we talk about in most people is, that we do screening for, is this item around aneurysm. An aneurysm being an abnormal blood vessel. The ones we really look for is in the brain they can form. And I love this picture. It basically shows what it is. It's kind of like a weak part of a blood vessel wall that balloons up, and in extreme cases can actually rupture or cause bleeding. And as you can imagine, if that happens in the brain, it can be quite bad. The short answer is that it's more common in people with polycystic disease. In the general population, it's less than 1%. Depending on what study you look at in polycystic disease, it would be 4 to 5%. If you have polycystic disease and you come from a family where someone's had an aneurysm, then it's like 20%, meaning it does kind of run in families. Those people need to be monitored very, very closely for this. Everybody else, because it is more common in the background, actually it's something we discuss with everybody, and a lot of people we do end up going ahead of screening for it. Most of what we find are aneurysms we never need to do anything about, but it is an important part of the care because the outcome of this can be so bad that we do go looking for it. Okay, so that's the management options. Now, the last part, I just had a couple of little slides just on longer term outlook because we get this question quite often. And I'll do this for maybe just a minute or two, and then we'll get to the questions here. Now, as we talked about earlier, this is a progressive disease. And I like to always tell my patients this, meaning it could sometimes be discouraging when you're doing your test and you see your kidney function going down, but it doesn't mean you did anything wrong, right? This is a genetic disease that by nature will progress over time, okay? And so it is expected that we see that happen. We try to slow it down as much as we can, but we will see that happen. So ultimately, we will get to a point where the kidney function, goes lower, and this is where we really start a lot of these kind of chronic kidney disease, as we call it, or these lower kidney function type of monitoring. When people get into this realm, that's where we're doing more testing to see the progress of the disease. I have some things there at the bottom that's really talking about symptoms of kidneys not working. Again, even more so than polycystic disease, the first thing people notice is nothing. By the time you start to notice symptoms, your kidney function is actually quite low for when these things might come up. But yes, it could progress in some people. And the part I really wanted to get to is to talk about some of the treatment options, just what that means in the context of someone with polycystic disease. Because people do know that in any type of kidney disease, when the kidney function goes down, we're looking at things like transplants or dialysis. Now, transplants, when it's an option, is the preferred option for most people. Especially so in people with polycystic disease for a couple of reasons. One question that I often get is, if we get a transplant, do I have to worry about the disease recurring? And the answer is no, because that transplant has somebody else's genes in it, meaning it fixes that issue as far as the kidneys go. So that's one reason it's a good fit. And the other is that polycystic disease tends to be what we call a single system issue, meaning unlike somebody who's got kidney disease because they've had diabetes for many years and heart disease and high blood pressure and all these things, kind of a one problem thing, meaning if you fix that, people do very well. And so this is why it can be quite a good fit. But then there's obviously the challenge of having to find a donor if for example, everyone in your family has a condition, right? So it's kind of a double-edged sword. People with polycystic disease could do quite well with a transplant. Sometimes it means their donor pool is a little bit more limited. So if transplant's not an option, we do have dialysis options. And I'm not going to go into the details here, especially in the interest of time. I mainly wanted to mention it because this question comes up a lot and to point people to kind of the right resources for it. So we do have, again, I keep pointing to ours, these are the ones I know on the BC Renal website, but there's a whole host of resources out there that really talk you through the different options if you're getting to that point. One specific item that I like to mention is that although, there's just two different ways of doing dialysis, one called peritoneal dialysis. Some people had thought in the past maybe that one wasn't an option with polycystic disease, but actually we have a large number of people in BC who do this type of dialysis, meaning even if you have the big cyst, there's some nuances we need to think about, but it's definitely an option. So all these options are available to you, if it need be. Again, that's not really being the focus, but since it comes up a lot, I just wanted to make sure people know there are great resources to help guide you through and select, what treatment's going to be a good option for you if this is, the point that you're getting at. Maybe I did these out of order, actually, because we talked about the different options and some specific considerations around transplant, which I actually mentioned, those two ones down there. So we kind of already covered that. Yes, but otherwise, so that was our whirlwind tour of the whole spectrum of polycystic disease, right from the beginning and through to the end. Hopefully that wasn't too much, but if so, please go, rewatch. And now we've got a few minutes for questions if anybody has any.
Thank you so much, Dr. Bevilacqua. That was an amazing, even if it was a whirlwind, it was an amazing introduction for people who didn't already have that information, and also focus on some of the things that are really common questions that we hear all the time here at the Foundation about having PKD and things that people have questions about. So for the people who are attending, if you do have any questions for Dr. Bevilacqua, please feel free to put them either in the comments or in the Q&A area. In the meantime, we do have questions that people have submitted ahead of time, and I'll try and pick out the ones that Dr. Bevilacqua hasn't already addressed in his presentation. One of the ones we had after our last patient forum, which was for Central Canada, someone had talked about he is 77 and his GFR is 26. And he's been told by his nephrologist that he's considered too frail for a transplant, but he's wondering because he hears other people who are, in their late 70s, early 80s having transplants. What's the difference between someone like that at that age having a transplant and what would be the things that may cause people to be considered not a good candidate at an advanced age?
Yeah, it's a good question. So there's not, depending province to province, I can tell you in BC, there's not a really hard age cutoff for transplant. As a general rule, we say, once you get past about 80, 85 is kind of the cap, then it can be a bit tricky. Now, it's individual to each person. When the transplant team is looking at someone, I'm not a transplant nephrologist, but I do things with transplant. When they're looking at someone, what they're really thinking of is, as you can imagine, when someone gets a transplant, although it's a great treatment, there is a little bit of risk up front, right? Like you have to make it through the surgery, the immediate time around that, and then all the medications. So when they're really looking at is, do they think somebody would be able to, withstand that risk and then still have enough lifespan on the other end to get the benefit? In other words, you kind of have to sort of, make it through and then have enough time ahead of you that you get the benefit of doing that transplant, as opposed to saying, actually, we're increasing your risk compared to doing something like dialysis, for example. So that's really what they're thinking of. It's not that they want to deny someone a transplant or that they're being ageist or something like that. They're really thinking of, are we putting you at more risk than benefit compared to, the alternative treatment that we have?
Right. Thank you for that answer. Someone was asking, they worry about the abdominal pain that they do have. How can they tell if the pain they're having is related to cysts or it's not something else, like maybe a cancer or something? When you were talking about those charts, what are some of the things that a patient should be aware of themselves when they're monitoring their own pain, and when should they go to their nephrologist or to a doctor?
Yeah, that's a great question, and that's where I really, advocate for the concept of what we call that pain journaling. That's one of the things that we talk about, in that other talk that I was mentioning. Really understanding your pain and that journaling, because what it does is it makes you kind of put into words to describe it and kind of recognize what's making it better or worse, or things like that. And one of the things that makes that helpful, to answer your question, is that you then can really tell when something is different or changing. Because that's kind of our trigger when we go looking and doing more testing, is when there's something very different, that's happening now compared to before. That'll often be a trigger to say, okay, maybe we should do another scan and see what's going on in there. So to answer that question, that's the really important point of understanding what you've been living with, and when there's something, oh, you know what, this is different than what I usually have, and that's something to kind of bring forward. So understanding your body is a big part of that.
Sure. Another question we had related to taking hormone when you're a menopausal
Right.
age. Does that have any effect on polycystic diseases?
That's an excellent question. So, when I mentioned earlier, I was going over it a bit quickly because of the topic, but the liver cyst specifically can be influenced by estrogen. And actually, for that reason, in somebody who has a lot of liver cystic involvement, both, hormone replacement, also sometimes even contraception pills, like going much earlier in life, right? We're careful about the types we use. So the answer is that estrogen effect that I mentioned, that's specifically for the liver, not the kidney. So to be very clear, it has no impact on that. So really the people we're careful about are the ones with more involvement. Meaning if you got one or two cysts in the liver, actually it's not going to make any difference at all. I've got no problem with patients like that, having it. But if there's more involvement, that's where we might look. And it's actually specifically the estrogen. Other hormone, forms don't have that same impact. Really good question.
Awesome, thank you. Another question I've had from a patient relates to anemia, and that they were experiencing anemia but weren't aware that that might be related to their PKD.
Yeah, good question. So it also depends when that comes up. And in other words, sometimes there is a temptation to, when someone's got any kind of condition, whether it's PKD or something else, to kind of say everything's related to that, right? And it's often we're taking a step back. So to this question, what I mean by that is, let's say somebody's very early in their polycystic disease, pathway, and they have a lot of trouble with anemia. It's true that later in kidney disease, you can have anemia issues, but when that's disproportionate, it might actually be that there's something totally different going on. So I often tell people, especially if they're early on, actually, just because you have one condition doesn't mean you can ignore everything else, right? You got to go look to see, is there a different reason behind it? But then, yeah, as things get more advanced, it is possible. A lot of those same general, as we call them, complications of chronic kidney disease, basically as the function starts to get impaired, can come up. And yes, anemia can be one of them.
Awesome. The last question I have, unless anyone else wants to add a question, is about the timing of trying to seek out a transplant. And I hear from patients a lot that, their GFR may be, sort of around the 20 area, and they're kind of anxious themselves to not have to go on dialysis, but they're not clear at what point it would be a good idea to have a transplant as opposed to continuing with the kidneys that they have for as long as possible. What are some of the things that the doctor would weigh when trying to decide when is the best time to have a transplant?
Yeah, it's a really good question. Maybe a couple parts of it. So I've got some patients who are, maybe we'll go to the extreme, who have got lower function and they're starting to have a lot of complications from their kidneys. And, we'll say just, pardon my French, but can we just get these damn things out and get a transplant done to be better off? And, the answer there is, as you can imagine, with that whole risk-benefit balance, although I certainly understand the sentiment, the transplant doctors, outside of very rare situations, aren't going to do it while the kidneys are still working. So they kind of will wait till it's getting to the point where the kidneys are not functioning, just to, again, say it's worth putting you through the risks of all this surgery. Now, in terms of so that's when we'll actually go ahead and do it. In terms of seeking someone out, I love the concept of doing it early. One of those roles that you mentioned that I'm very involved in is what we call preemptive transplantation, meaning aiming for a transplant before someone ever needs dialysis is the best way to go. So, and the numbers you quoted, that's actually what I tell people as about my rule of thumb. Once people are getting close to about 20, for example, that still gives you lots of time to get all the testing in place so that you're ready to go before you get to that point that you need to do. We don't do it much earlier, because I also get the question, hey, I know this is coming. Why don't I just get something ready to go, get a donor lined up 10 years in advance? And the main reason for that is because of all the testing that needs to happen. If we do it too early, you just need to do it again later on. So we kind of wait till it's a little bit more just in time. So yeah, that's about the rule of thumb I actually use for my patients. Once you get around about 20, it's time to start getting everything in place.
Awesome. Well, thank you so much. I'm not seeing any other questions from the participants tonight. So just want to tell you how much we appreciate you taking the time to share all of this information with us. It's been very helpful. I know because I hear on a daily basis the questions that the PKD patients have, and this has really helped, us being able to point them to information, and having this recording will be a really great thing.
My pleasure. Absolute pleasure always to be involved with the great work you guys are doing. Thanks for having me again.
Great. Thank you so much, and have a good evening, Dr. Bevilacqua.
Thanks, you too now.
We'll now turn to today's patient story from Kelly Konieczny. Kelly is a PKD patient living in Alberta. She is a passionate advocate for living organ donation and is currently seeking a living kidney donor. This is Kelly's story. So to start with, Kelly, why don't you tell us a little bit about your family history and sort of what whether there were people in your family that had PKD, and when you found out that you had PKD.
So I found out when I was 21, which was approximately 29 years ago. And honestly, at that time, after hearing from Dr. Mike here, lots of things have changed since then. I had no idea that my family had this disease. We still don't know 100% for sure where it comes, but we've kind of traced back, and we think probably from my mom's side of the family. So it was kind of a shock to us. And I think just with the way things were even that long ago, it didn't seem like a real urgent issue. And it was, I remember my nephrologist saying to me in these exact words, probably by the time that you're 50, you'll need a transplant, which to me was 30 some years in the future. And I wasn't, completely focused on that as a 20-year-old. So that's kind of how it all arose for our family. And I have just been really diligently in the last 15 years, I would say, learning as much as I can, kind of when my, symptoms started worsening, and we were going to have to start looking for, maybe treatments, transplants, things like that. And now I've been looking for almost 5 years for a transplant.
So at what point, because I know you are on dialysis now, at what point did the dialysis come, before or after you were starting to look for a kidney donor?
Yeah, and this is all kind of, like I said, even though I'm just in the midst of looking for a transplant, and things have just changed in the last 10 years, like the doctor said, it never was really an urgency to look for a transplant. I was really given no knowledge or guidance, information on that. It was just, we'll talk to you once a year. And the main question they always asked me was, do I have stomach pain? So the pain journal will be helpful. And it was always no, because I didn't. And then all of a sudden it was like, oh, your GFR is this, and we're going to have to start getting you prepped for dialysis. And I was thinking I could have been more active in this if I had have known. So I didn't start looking for a transplant until about a year before I had to start dialysis. And I just assumed that I was going to have no problem getting a match, because I had several people wanting to help me. Including my family too, but again, sort of, not really being educated in it, and the way that PKD works through the family. My family, it wasn't going to work for me. They were all tested and not capable of donating. And the other thing that I kind of got bounced with was that I had 100% antibody sensitivity, which I didn't even know was a thing. In all honesty, I thought it was just blood compatibility. And so that really threw a wrench into things too, because if I had have known that much earlier, a sense of urgency probably would have got me going a lot earlier. But I got this sensitivity from my 3 pregnancies, which again, I had no idea that that was even a possibility. So all these little things kind of just piled up without me even knowing that they were a possibility of piling up. So I now have been on dialysis for, it'll be 4 years in November, and I've been actively looking for a transplant for about 5 years.
Right. And can you tell us a little bit about how the transplant cycles work that you had told me before we started that one is just about to start, for people who
Yes.
aren't aware kind of how that works.
Right. So again, this is all something new for my line of in my family. And like I said, I have 3 daughters. So if anything, I'm learning all this, and I know that they'll be even steps ahead of me from me entering this. But I started looking for living donors, of course. So sharing my story, passing it to family and friends, and making social media accounts, getting bumper stickers made and things like that. So I am on the living donor train myself. I'm also on the paired exchange, which runs this week. We should be getting results for that next week. And that is, of course, the Canada-wide exchange, in which you can be put in with people who are willing to come into the exchange with you, to make chains, to, mix and match people throughout Canada. And I've been on that for, again, 4.5, 5 years, nothing yet. But so there's that. And then there is a deceased list as well, which we all know is very needed. But the wait for that is very long, and it's quite specific, as you can imagine. So that's kind of province-wide mostly. But for me, who I'm highly sensitized, they put you on the Canada-wide for that as well. So there are options, but your best bet is to be your own advocate and to keep pushing for information being more relevant about living donor for a long, long time. Again, even just as a person, a citizen myself, I just always thought, oh, well, a deceased donor is the only way that you can get a transplant. But it is coming more common that living donation is a wonderful way to help those of us on the list. And for livers and kidneys, you can share one or part of your liver and still live a long and healthy, active lifestyle. So I've actually joined an alliance, a Canadian-wide alliance, and we are sort of promoting that, in that we want more information to be shared about living donation, and make that just as important for nephrologists to share as going on dialysis. So
you've talked a few times about when you were younger, there were things you just weren't aware of. If you could go back in time and give some advice to your younger self, or give some advice to other people who are at an earlier stage of disease, is there any additional advice that you would give to them?
Oh, several. Like I said, I think leaps and bounds have been made just in the program itself. Even hearing from the doctor tonight, it's nice that things have even come in the last 10 years. I do find it a little bit frustrating, maybe, that each province is so different, and that the transplant programs are different. I guess the willingness to share, or just the transparency and an accountability maybe is quite varied throughout the country, and that's maybe a little bit disappointing. So I would say to do your research on your own. Don't just listen to what you're told from your doctor. Like, many of the times you're just getting started just with a family doctor, and they are not specialists. If you feel like something isn't right, you feel like you want extra testing, you feel like you just want extra opinion, make sure you're advocating for yourself, and to do your research so that you know what you're looking at, and how you can help yourself instead of just always relying on somebody else to do it for you. I would also say to ask lots of questions and get second opinions. For me specifically, and this might be for other people too, is to learn your sensitivity or HSP, because had I known that I was going to have such a high sensitivity, like I said, maybe I would have started looking a little bit sooner. And that's something I could have shared with more people, being that, okay, now I'm going to be a little bit harder to match. But I didn't know that even probably 2 years into being on dialysis. Like, I don't know why I wasn't told that right from the start, but I wasn't. So, and then I would say to research, your polycystic kidney disease or whatever disease is causing you to have your issues. Start looking for donors early. Share your story, be a strong advocate, and really try to, I guess, work on your lifestyle, your stressors, your exercise, your eating properly, watching, your sodium intakes and all those things, blood pressure, and just kind of have an idea of how that's progressing on your own so that you can help your nephrologists and your doctors as much as you can. Yeah. And I guess also that, I guess that that polycystic kidney disease is hereditary, and that, it is like a 50-50 chance that you're going to have it. And so trying to progress as far into your life as you can on a healthy note, and also being a role model for those under you. So like I said, I didn't have anybody to lead me through this, but I am hoping to be a leader for my girls. And if they should ever have to, live through this like I am, maybe they'll get through and not have any issues. And that would be wonderful too.
Is there anything that you found especially helpful for you along the journey, whether it's things that help you with your mental health or advice you've received from any of your care professionals that you've seen? What are some of the things that have really been a help to you?
For me, in all honesty, it's been me choosing to help myself. And that was me making my lifestyle, doing things that I enjoy. And for me, that's, like that meditation and yoga and being in nature, and really trying to wrap that around how that'll help me physically and mentally. And having a support system at home, obviously. Lots of love and support, and people taking me to my doctor's appointments and things like that. I had been through several surgeries with my catheters, and I tried PD first, and then that didn't work, and then I had to put in this catheter and get the other one out, and then I had a kidney removed, and it was all through COVID, and it was very stressful. At the time, it was just automatic, but it's like anything after the fact, it was like PTSD, and it was like, wow, how did I do that? And it was because I had a strong system. So I would say to try to surround yourself with people who are able to help you navigate, because it is a huge mental game. It's just as much mental as it is physical, in all honesty. And just try to be positive. I would say for me, a belief system in my spirituality has been huge as well. So those are just things that I make sure that I do on the daily, getting exercise and being outside.
Thank you so much. I don't see any questions from any of the people watching. So I think we'll wrap it up now, but I just want to thank you so much, Kelly, for sharing, some of the very personal parts of your story and talking about how PKD has affected you and is still affecting you. We just really appreciate, because I know every time someone in the community shares their story, there's always someone who can relate to it and feel a little less alone.
Yeah, I agree. And that's partly using these systems like your webinars, being parts of groups on Instagram, sharing your story and getting feedback from other people, following other people who are on the journey with you so that you can relay stories back and forth and support each other. And I think being open and honest, don't try to sugarcoat things, and, voice your opinion, be a strong advocate for yourself and be supportive for other people, because that positive energy will just reciprocate for you too.
The PKD Foundation of Canada would like to thank both Dr. Bevilacqua and Kelly Konieczny for their presentations at this PKD Patient Forum. If you have additional questions that you would like us to ask nephrologists like Dr. Bevilacqua, feel free to email us anytime at endpkd@npkd.ca. Thank you.